Hello, friends. So, I'll be giving a bit of an overview on the advances in nutrition. So, I was meant to give as a part of our nutrition meet in Bangalore on 29th April. That's on Tuesday. So, this talk I've done in bit of parts earlier on. So, I've just collated it all together so that it's going to be useful for all our trainees as to what are the key advances in nutrition, sort of debunking the myths that sort of surround these nutritional practices. So we look into the first sort of a myth about whether delayed nutrition is something that at some point of time should be considered. So that's a huge myth. So any patient who comes in ICU, there are literally no contraindications to initiate enteral nutrition on admission. And another key aspect which possibly we need to bear in mind is not to attain the targets at the outset. So enteral nutrition with low to moderate calories and proteins as a goal to start at the outset and slowly build up and slowly cascade it up to attain the specified goals is what the norm says. And why enteral nutrition is preferred? Obviously, we all know it is to maintain gut function. If gut is working, one should use enteral nutrition because it helps in lot of internal milieu of the gut homeostasis, like production of trophic substances and maintenance of gut-associated lymphoid tissue and maintaining the gut microbiota. So these are all some of the intuitive sort of benefits of using enteral nutrition, and it also helps in preventing unnecessary parenteral nutrition that one may embark on. So that's something what we need to bear in mind. And if the gut works, you just have to use it. So that's the philosophy. And what's the meaning of early enteral nutrition? When we say early, what does that entitle? So when you look at the whole concept of early enteral nutrition, there are different guidelines. If you look at the Canadian and the ESPN guidelines, it should be initiated within 24 to 48 hours after admission. And even the ASPEN, American Society of Parenteral Enteral, suggests within 24 to 48 hours of admission to ICU, enteral nutrition has to be considered. And Australia and New Zealand goes a step forward in suggesting that enteral nutrition should be considered within 24 hours. So within 24 hours or 24 to 48 hours or as early as possible remains the norm. The gut is functioning, use it is the norm. So when you look at all the outcome studies of early, why we propose early enteral nutrition? Because very clearly, if you look at all the large data of all the studies that have been done, if you look at this huge, Helen has done a lot of work and took all the 7 randomized controlled trials with 440 patients. The group with early enteral nutrition has had a lower infection rate as compared to the group with delayed enteral nutrition, and they were significant. But that did not translate into mortality. When they look the same sort of RCTs or more than that, 14 RCTs they took, did not really translate into huge mortality difference, although there were signals towards lessened mortality, but it did not attain statistical, as you see, 10% versus 20%. And this is a little more recent study which has looked into ICU length of stay, which has come from Germany and Dutch group. And even here, it shows that ICU length of stay was significantly less in patients who were fed early. So there is enough body of evidence to suggest that early enteral nutrition is the way to go. And most intensivists who are hearing to me would sort of agree to this and would concur and converge on this. So the second myth that we tend to sort of sometimes follow is that post pyloric feed is maybe perhaps superior to gastric feeding. So for the ease of narrative, I would use the word small bowel nutrition versus gastric nutrition. So early gastric route, so if you don't need to aim for small bowel feeding, early gastric route is good enough and beneficial. So there are studies which has compared gastric and small bowel feeding and they found no difference. And we all understand, friends, that gastric tube or the Riles tube, which we call it, is easier to place and technically not as challenging as you would embark on putting a small bowel tube, and it is even quicker to put. So this I'm sure we're all aware. So is there any evidence for that? So there is evidence to suggest that gastric is as good as small bowel. So this was a nice trial, a multi-center randomized control trial comparing early nasojejunal versus nasogastric nutrition in critical illness by Australian group. So here they took the patients with who had high gastric residual volume within 72 hours and the randomized between gastric and small bowel nutrition, So there are 181 patients, 89 in the gastric group, 92 in the small bowel. And they looked at hospital mortality. There was no difference between gastric and small bowel. And in fact, the small bowel enteral nutrition, although had signals towards reduced risk of hospital-acquired pneumonia, which sort of gives it a bit of an advantage. And the nutrient delivery also, they looked at, there was no difference between gastric and small bowel. And the aspiration, which you would believe the small bowel nutrition would have less aspiration. So there was no significant difference between gastric or small bowel enteral nutrition. But there are special circumstances where small bowel enteral nutrition could be considered, like where you have delayed gastric emptying or foregut surgery or gastrectomy or very complex pancreatitis, you have undergone Whipple, so on and so forth, or gastrointestinal bypass. So these are very distinct cohort of patients where perhaps small bowel nutrition may be more feasible or not feasible, maybe more tolerable, and this would be desirable in these situations. So the other myth that possibly uh, one would argue is maybe perhaps continuous feeding is superior to bolus feeding. In fact, when earlier days when we had NABH sort of inspection, one of the NABH inspector who had some passion towards nutrition did argue with me saying that maybe we should adopt continuous feeding. And I had put forth the evidence to tell this gentleman that no, I think the bolus feeding, which we do it, is as good as continuous. And I had an sort of a show him the data in the audit and tell him that what we are doing is the right thing. So you may have, you just have to stick to the science, friends. So I mean, it may be an ABH, it may be a JCA inspector, doesn't matter. You have to stick to the science. So there is no difference between continuous and intermittent feeding. There's absolutely no difference, even if you look into the data. Although the claims are that continuous feeding will limit GI intolerance and glycemic sort of a variability is little less with continuous feeding is argued upon. But when you look at this large data, that came from Australian group. Again, they are pioneers in doing good nutritional study. In fact, I was fortunate enough to have trained under Dr. Marion Chapman, who is the proponent and who's possibly a legendary person in doing nutrition trials. So the comparison of continuous versus intermittent enteral feeding in critically ill patients, it's a meta-analysis. They took 14 trials and they compared between continuous and intermittent. So the only benefit of continuous, not benefit, sort of a the disadvantage of continuous was constipation was more in continuous as opposed to intermittent. And if you look at the mortality, there's no difference between continuous and intermittent. None of them, as you see, the confidence interval was statistically significant. The risk of infection, colonization, also there was no difference between continuous and intermittent. The risk of pneumonia, there was no difference. And the diarrhea, if you look at diarrhea, also there was no difference between continuous and intermittent. And the gastric residual volume, which you would think is possibly little more in the intermittent, even there was no difference between continuous. So basically, all the endpoints when they looked at, there was absolutely no difference between either you do continuous or intermittent. One could argue we don't keep eating continuous, isn't it? We do eat sort of intermittently. So the bolus feeds is more physiological and it limits interruptions and it also helps in mobilizing because when you're doing continuous feeds, sometimes that could be a reason to interrupt the sort of mobilization. And even bolus feeding is found to be safe even when you're doing jejunal or gastric feeding. And the nighttime feeds, I'm sure most hospitals would give a sort of a halt and wouldn't continue the feeding in the night. And if feeding in the night has shown to cause circadian malalignment from these studies from Spain and UK. And it is shown that inappropriate feeding at the night time increases the risk for cardiometabolic syndrome. So these are some of the disadvantages of continuous feeding extending to the night can be in fact harmful as opposed to any benefit. And these are all the forest plots which pretty much sort of commensurates to the data that I showed. So mortality, there was no difference. Pneumonia, there was no difference. So the myth four, which till very recently we had this notion that high gastric residual volumes you should stop feeding, and this has been debunked. So even gastric residual volumes is something that we should not be fixated to, although you have to monitor whether there is a feed intolerance that is happening due to gastroparesis, but routine monitoring of gastric residual, like before we had the days where nurses used to aspirate and see if the gastric residual volume was more, they would stop the feeding. So now that 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 has been debunked and one is not meant to do gastric aspirate check for gastric residual volume. But of course, you would monitor where if patient has ongoing vomiting, imaging shows a huge dilated stomach or ileus, and the bowel sounds are absent, you would take a notice and you may have to calibrate your feeding sort of a principles, but you wouldn't be routinely monitoring gastric residual volume. So that is the notion. And gastric residual volume had no correlation, although you would think that increased gastric residual volumes leads to aspiration. Studies have shown it had no correlation with the aspiration. And are there studies? So this is a nice study that came in JAMA from the French groups. The effect of not monitoring residual gastric volume on risk of ventilator-associated pneumonia in adults receiving mechanical ventilation and early feeding. It was a randomized controlled trial done in mechanically ventilated patients where they compared groups between residual volumes and no gastric residual volumes, and they found there was absolutely no correlation with regards to ICU complication. In fact, the patients who had no gastric residual volumes tended to have increase in the target calories, which is understandable because if you have gastric residual volumes, obviously the calorie targets that you may have could possibly would not be achieved. And this was a nice trial called a regain trial where they compared two different quantities or the units of gastric residual volumes and to see if there's any difference from the Spanish group multicentric randomized controlled trial where they compared the group with gastric residual volume of 500 ml or more and versus the group with gastric residual volume of 200 ml. And they found no difference with regards to any outcomes. So there was no difference with regards to GI complications. There was no difference with regards to ICU acquired pneumonia. There was no difference with regards to duration of mechanical ventilation or ICU and hospital. So basically, all the endpoints they looked at, either with more than 500 gastric residual versus 200, there was no. So with this particular study possibly put a sort of end to the debate that we don't need to monitor gastric residual volume and it is not a risk for aspiration. And Aspen 2016 recommends against the use of gastric residual volume. So that is the notion and that is the submission that we have at this point of time from the scientific standpoint. And the myth five, so this is interesting, friends. So see, very often put your hands on your chest, ask yourself how many patients we fast when they're posted for some orthopedic surgery or non-abdominal surgery. So the notion is if your airway is protected, you and if it is not a thoracic surgery, abdominal surgery, or surgery needing a prone position, you do not have to stop the feeding, and they can be fed until they are wheeled into theater. Like typically the orthopedic surgery, the limb surgery, or even possibly the neurosurgery, you don't need to fast them overnight, which we are doing. In my ICU also, we may be doing in some patients, and we need to revise this and one third of the patients get fasted if you look at the data, and 25% of the cessation time happens in their feeding, which has shown, the studies have shown that it leads to nutrition deficit. It has in fact showed increase in the ICU and hospital length of stay and has led to increase in the ileus. So most, I think this really applies to our trauma patients where they are wheeled in for surgery every alternate day. If it's a polytrauma, some limb surgery, some fasciotomy, or some sort of a maxillofacial surgery, so on and so forth. Just imagine you fast every sort of a night and you don't feed for an extended period of time. So you would be compromising on a lot of nutrition deficits and in fact, it is shown to lead to ileus. So the norm is to take them through the feeding from perioperative to intraoperative is the norm and it is shown to reduce the risk of infections. And what is the sixth myth? And abdominal surgeries. Put your hands on your chest, friends. Any patients who's had abdominal surgery, even today, we tend to delay feeding, whilst the data very clearly shows there is improved outcomes if you feed them early. And what is the notion now? That we feed them with clear water, liquid diet, solid, but the evidence clearly says go solid. And even I'm not able to do it in my ICU with our surgeons because we are not going solid at the outset. We start with clear water, which is not the right thing to do. So recommendation 6 is within 24 hours, you feed after a major abdominal surgery, shown to reduce mortality, reduce bowel edema, reduce the ileus. And even in patients with fresh anastomosis, so anytime there is a fresh anastomosis, they'll have a leak. So no, I think the studies have shown, in fact, it reduces the risk of the leak. Early enteral nutrition is the way to go. Early enteral nutrition is safe in reducing the complications, and even it reduces the time to abdominal closure and reduces. So there is so much data to tell that even after anastomotic surgery, early feeding with solids and not delaying has shown improved outcome, reduced infection, reduced ileus, and reduced leakage and reduced mortality itself. And what is the data? Look at this study, early enteral nutrition within 24 hours of intestinal surgery versus late. A systematic review, 1,000 patients, 13 trials has shown reduced mortality from 6.8% to 2.4%. Surgeons, please hear me out. 6.8 to 2.4% reduction in mortality if you feed them early rather than late. And this is the forest plot. You can see the P is 0.03. It's very significant. You take all the trials, put them in the basket, analyze it. It has shown improved sort of a survival if they're early fed in patients with intestinal surgery. And even anastomotic decisions, which argue you feed early, they will have some anastomotic leak. But they have shown that there is no difference with anastomotic leak. So please hear me out, surgeons. I think we are doing a great deal of malpractice in not feeding them early. So enteral nutrition should be delayed. Again, they have shown there is no worsening effect on the dehiscence, and enteral nutrition possibly have to be held where you have a suspicion of ongoing ischemia, bowel obstruction, inflammatory condition, or bowel continuity is lost due to perforation or so on and so forth. And there's no evidence that you start with clear liquids. In fact, there is a suggestion that solid foods may be helpful, and clear liquids has not shown to reduce feed intolerance. And even if there is some sort of a esophageal perforation or some sort of a, so you can go distally and start feeding, like feeding jejunostomy or jejunal feeds or small bowel enteral nutrition has to be initiated. You can go distal and start feeding is the norm. And the seventh myth, which in ICU we tend to encounter, especially proning, is become a norm in ICU. Prone and paralyzed should be fasted. So I'm sure most intensivists were hearing to me, we don't follow this. We feed all our prone patients. We are very good. I think we are much, much better than what the evidence shows and what the practices are in our contrarian specialty groups like surgical group. We intensivists follow good evidence-based evidence. So increased gastric residual volume and vomiting is sort of contemplated as a reason, but recommendation says that you have to continue to feed. Is there any data? So this is a nice Italian study, nursing issues in enteral nutrition during prone position. Again, a systematic review. 6 studies, they compared supine and prone. There is no difference with regards to gastric residual volume. They looked at ventilator-associated pneumonia, length of stay, mortality. There was no difference between supine and prone. And the notion or the hypothesis one had was neuromuscular blockers will relax the smooth muscles of the stomach and they don't sort of tolerate. And it has shown that neuromuscular blockers had no effect on the gastric motility. And enteral nutrition in prone position has shown, this is a Japanese study, reduced mortality, reduced in hospital acquired pneumonia, reduced ICU and hospital length of stay. So we have clear data to say even in prone, feed them early, it has shown to show reduction, good outcome measures. And what about when patients are on vasopressors? Intensivists are very good. They continue to feed once your hemodynamic stability has attained. So obviously, when someone is hemodynamic very unstable on a cascading vasopressors, no intensivist is a fool to continue feeding. They would possibly stop or reduce the feeding. So the Aspen guidelines also suggest enteral nutrition can be held if MAP is less than 50 with ongoing hemodynamic instability or cascading or escalating doses of vasopressors. You can hold it. So that I think every intensivist is following. Our intensivists are brilliant and can be resumed. Once hemodynamic stability is attained, vasopressor dose is stabilized, you can reinitiate your vasopressors. And there is this Japanese study which has shown that norepinephrine at a moderate dose, if norepinephrine is less than 0.3 micrograms, early enteral nutrition has in fact shown reduction in 28-day mortality. So even in hypotensive patients, once hemodynamic stability is maintained, and there is vasopressor need has sort of stabilized without escalating doses, it has shown to improve the outcome. And this is the last myth, enteral nutrition should be held before extubation. So this sometimes some people do, we don't do it in our ICU, we just do the aspiration. There will be a Rayleigh tube in most of them or an nasogastric tube, we just aspirate the stomach contents and extubate. You don't need to fast them. So feed need not be held before extubation, but there are no explicit guidelines. But is there studies? Yes, there is a trial for this, which came as late as 2023 from French group. Continued enteral nutrition until extubation, compared with fasting before extubation, an open label randomized trial. 1,130, they looked between continuous enteral nutrition and 6 hours fasting before extubation. Extubation failure, there was no difference. They looked at pneumonia in 14 days. Within 14 days, it was found to be lower where feed was continued until extubation. I don't know how you would explain this. So my only suggestion is before extubation, use your common sense. just aspirate your nasogastric tube with all the stomach contents before, just because after extubation they'll cough and splutter, and they may have a sort of a emetic reflex, and they may start vomiting. And if the GCS is borderline, there can be risk of aspiration. Just use common sense, do Riles tube aspiration, and then extubate. So that's all is there, folks, on all the recent update on nutrition, debunking the myths that sort of revolve around our nutrition practices. So I've just put everything together. There were talks before which had this in a staggered format with more detailing into some of the studies. So I've just kept it simple for all our trainees. So thank you, friends. Request you all to submit your valuable work to Journal of Acute Care. Of course, visit my website to rehear to this lecture. So thank you one and all. And it's a nice quote: be with people who know your value, not your price. Thank you, friends. Thank you.